Hey guys, I wanted to review what we talked about this week in lower quarter. We had two different case scenarios. One was a person with pelvic girdle pain, and another was lumbar radiculopathy. Both of them fairly common scenarios. The first one we talked about was pelvic girdle pain, and how the patient came in with some maladaptive beliefs or unhelpful beliefs about the structure of her pelvis, the need to strengthen her core based on what she'd been told from her chiropractor and others. So not an uncommon scenario, and it can be tricky to deal with these situations. I really like what most of you guys said on, you have to be delicate and careful with this. You don't want to throw the other provider under the bus. You don't want to come on too strong if this patient's got firmly held beliefs, because it could backfire on you. So I think you'd have to kind of feel it out, maybe get some trust, develop a rapport over a few sessions before you really got into that. The main thing you could try to do initially is just get that patient moving better. She's guarded, she's fearful, and sometimes if you can get them moving better, decrease that sort of guarding, improve that movement quality, and they feel better, they might be more likely to listen to you. So just pointing those things out, that they're tensing, they're guarding, show them in the mirror, take a video, whatever you need to do to kind of change those movement patterns, incorporating that with education on, really, if you look at the pelvis, it's a strong structure. It's very unlikely to come out of place without major trauma because of the ligaments, all of this. And, it might appear that your spine is out of alignment, but it's likely more due to your muscles tightening up, tensing and protecting your pelvis and your back. That's a lot of times what I'll tell people, that it gives that appearance, and sometimes when you do manual therapy, it can seem to realign because the muscles relax. Most people understand that, they buy into it, and if you come across as credible, not like a know-it-all, but just be confident in what you're telling them. It's basic anatomy and biomechanics that the pelvis doesn't move that much, the ligaments are strong, it's made to be a load-bearing structure. I think you can really help people come around, and then also help them to understand, particularly in this case, she's postpartum. There's a lot of things going on in her life that would increase the sensitivity or sensitize those structures. So helping her to see that bigger picture, not blaming all that on her pain, still looking at, the movement part of it, but also realizing how the stress, the lack of sleep, the maybe social isolation from not working anymore can contribute to the pain experience. It still surprises me that there is PTs, chiros, docs that still perpetuate this structural model of the pelvis being out of alignment and biomechanics. I mean, the evidence out there is it's hard to refute at this point. It's really almost like we shouldn't even need to study that anymore and just sort of move on from that. But people are still perpetuating it. It's still taught in some PT programs. My students certainly have CIs that do it. So it's out there, and we need to do a job of helping our patients to have a more healthy belief around these issues. The patient with radiculopathy, once again, I thought you guys did a good job. It's a very common scenario. Patient comes in with a radic, imaging findings correlate, and in this case, I would say the imaging findings are relevant. Big disc herniation that is, matching up with the patient's symptoms. Certainly, that's probably a relevant finding on the MRI, because that's not one of those incidental findings that you have a major, like, posterior lateral disc protrusion. A disc bulge, yes, or degenerative changes. All those things are common in asymptomatics, but this kind of thing is not very common in people without pain. So it's probably a relevant finding. And as I mentioned, the evidence for surgery is decent, and you can have good short-term changes. People tend to get better with that type of surgery, particularly if their main issue is that they have leg symptoms, tends to take care of those. The back, if it's more back than leg symptoms, the back symptoms don't tend to get as better as the leg symptoms. So that's something a good surgeon might ask, is what's the percentage of your pain from your leg versus your back? If it's mostly back, they tend maybe not to operate on them. It depends on the surgeon. But anyways, the evidence would also show that patients can get better with a variety of conservative treatments or just passage of time. So patients need to be aware of that. They need to have an informed choice about their surgery. Any kind of surgical procedure is going to carry risks. The risks are probably minimal with this type of surgery. It's not super invasive. They do a microdiscectomy. However, we do know that once you've had one surgery, your probability of having a second one goes up. So I'll try, if I can, to steer patients away from surgery, particularly if they're getting better with passage of time or conservative management. Over the weekend, we'll talk about some strategies for working with these patients. One thing I haven't found that useful for patients with like a true radic is the McKenzie stuff. And we can talk about that, but I just haven't seen someone with like a full-on acute radiculopathy, walk out fully centralized. It doesn't make sense to me that it would happen anyways if you have this, sort of acute disc protrusion. What are you going to push it back in with McKenzie treatment? So we'll sort of talk about that on the weekend, but I thought all you guys had some good points with that. And the other thing that I mentioned is we need to take the pressure off ourselves as PTs within these situations that we're going to fix these patients. Not realistic if you think about just normal physiology of what's going on there, tissue healing times, the time it takes for a nerve to sort of calm back down. You're very unlikely to fix somebody in a short period of time. Can we get them moving and feeling better? Yeah, we probably can. Can we give education so they are reassured? Definitely. But I'm not going to say, well, in the next 4 weeks, you're going to be all better. It's going to be unrealistic. So just something to keep in mind. So great job on the discussions. You guys were more timely this week, so keep that up. I'm going to stay on you for that, to keep you honest with this stuff, because I do think it's helpful to read about it, talk about it, and have some time to digest it. Looking forward to this weekend, so I'll see you guys soon.